In this chapter of general critical care, there are just certain pathologies and disorders that are particularly important for the adult critical care. And so in this chapter, we're going to take a look at those areas. Now, some are going to be more important than others. We'll get into the details of those. Others, just a general understanding will be all we need for the exam, and we'll point that out as we proceed. The content outline lists all the different areas we're going to take a look at. We'll just jump into the first one, which is acute respiratory failure, or ARDS. Now, acute respiratory failure, this is something that is defined there for you. It's the inability of the respiratory system to meet the demands for ventilation, oxygenation, metabolic requirements, whatever. Basically, they're going into failure, and we see this all the time. It'll be easy to identify. This can be associated with just about any pathology, so it's not a specific pathology, it's a complication that develops with almost any pathology, whether it's cardiovascular or neurological or trauma or whatever. Any patient could essentially go into acute respiratory failure. So this is going to be a common one that we see throughout the exam, regardless of the pathology involved. It describes that there are three types. The first type listed there is hypoxemic, and that's the most common. This is where the oxygenation is falling, and they're just unable to maintain good oxygenation. The PO2 will drop. We've talked about some of these calculations in patient assessment. The PF ratio here is described as being less than 300. We know the lower that number gets, the worse it is. And then the second type is described as hypercapnic. This is when the PCO2 is rising. And so we know that they're going into full ventilatory failure. So initially it's failure to oxygenate, then it becomes failure to ventilate, and that leads to number 3, which is a combination of the two. All right. Now the causes are listed there, and as I said, just about any condition could lead into a respiratory failure. So it's not the pathology that's important, it's monitoring the patient and seeing what's going on with them. As far as assessment and diagnostic testing, those are listed there for you, but a blood gas is going to be your primary tool. It's going to show you that they're becoming hypoxic. Certainly, saturations can be monitored. You can do some of those calculations we talked about, the AA gradient, the PF ratio mentioned already. All of these things that help us take a look at oxygenation can be used, but the main tool we're going to see on the exam is a blood gas. And you'll see the PO2 falling, saturation falling, and that indicates failure to oxygenate, and we have to treat that, of course. And then if it's hypercapnic, meaning they're failing to ventilate, then the CO2 will show that in the blood gas. And we did that again in patient assessment. We looked at blood gases. So first thing we always want to check is ventilation, because that's the highest priority. So when we look at the CO2 of the blood gas and we see it's rising to a high level, other parameters that could be used to monitor ventilation are listed. Vital capacity is one of the most important ones. We'll see that emphasized when we get into mechanical ventilation. But if the vital capacity is dropping below 10 milliliters per kilogram, then that's considered an indication of ventilatory failure. Another number they like to use is the MIP, or maximum inspiratory pressure. And when that's dropping below a value of 20, now it'll say negative 20, but be careful. The negative sign is simply indicating that they're inhaling and not exhaling. But the level is 20 centimeters of water. So when they're inhaling, how much pressure can they generate when they're inhaling? Okay, is 20 centimeters of water. So if it's decreasing below that, the number would be decreasing, 19, 18, 17, numbers less than 20. Okay, sometimes people get confused on that because technically if this was a negative number, then negative 19, 18 would be a higher number. But it's not a negative number. The negative sign is simply indicating the direction or the vector, and that direction is inspiratory instead of expiratory. That's the only distinction. So disregard the negative sign. 20 is the number, and it should be more like 40, 50, or more. So if it's dropping below 20, numbers less than 20, 19, 18, 17, that's bad, and that indicates that they don't have the muscle strength they need to ventilate. So we should be able to quickly identify if somebody is hypoxic from the blood gas, and also if they're not ventilating adequately, hypercapnia should also be from the blood gas. That'll be the main tool to identify this. As you read through the notes, it'll describe the clinical manifestations of what's going to happen. You know, if somebody's not ventilating, CO2 is building up, that affects their mental status. Also, if they're not getting oxygen to their brain, that'll affect it. You can have changes in the heart, you can have cyanosis, diaphoresis, and so on. All these things can manifest itself when somebody's going into failure. Now, acute respiratory distress syndrome is described here. We saw this before again in the assessment chapter, but it's describing the classification using the ATS-ERS criteria of acute lung injury versus ARDS, or more commonly now we're seeing the Berlin criteria, which separates it into mild, moderate, and severe ARDS using the PF ratio. So the higher the PF ratio, the better. So if it's dropping below 300, then we say it's mild. Dropping below 200 is moderate. Dropping below 100 is severe. And so that's a criteria you want to be familiar with. Management is pretty straightforward. If it's hypoxemia, you give them oxygen. And whatever amount of oxygen they need, that's what you provide. So what you see in your book is describing everything from a low-flow nasal cannula, which could give 30, 40, 50%, all the way up to a non-rebreather that delivers 100%. So it's whatever is required for the patient at that time. If they are going into ventilatory failure, then mechanical ventilation will be required. And we'll see that as well in the exam. We'll talk about that when we get to that section on mechanical ventilation. So we're talking about a patient, regardless of their pathology, where they're having trouble maintaining good oxygenation, so we're treating that, or they're having trouble maintaining adequate ventilation, so we're treating that. The drugs involved here, as we said, we're going to talk about the drugs as we go. So drugs that are commonly associated with this problem would be inhaled beta-2 agonists. That's if there's having any bronchospasm associated with this. Anticholinergic agents, the ipratropium bromide, that also relieves bronchospasm. We'll see that sometimes as well, particularly with lung patients, pulmonary patients. Corticosteroids can also be important if there's inflammation, again, depending upon the underlying pathology, and that can vary from patient to patient, but if there's an inflammation, then certainly steroids can be appropriate. Inhaled nitric oxide can be used if that's indicated. That's a pulmonary vasodilator to reduce pulmonary hypertension if there's a pulmonary problem. Sedation might be necessary if the patient's agitated or fighting, and so benzodiazepines will be used. If it gets even more serious, we may have to use paralysis drugs. That's the vercuronium, pancuronium, any kind of curonium is going to give you muscle relaxation or essentially paralyze the patient so they can't be fighting, and that might be helpful to them if they can be sedated and paralyzed. It lists mucolytics. That's kind of the last thing we might see. We don't often use mucolytics. They'd have to have a significant secretion issue for that to be indicated, but it's listed here for completion's sake. Antibiotics could be indicated if they have an infection. That could be the underlying pathology. And then bronchial hygiene, if they have a need for that. A cystic fibrosis patient, obviously, always going to have issues with secretions, and so that could be a part of it too. So the care really depends upon the underlying pathology that's involved. The primary care is to maintain good ventilation and good oxygenation, as always. That's our life function. And then the underlying pathology will dictate the rest of our therapy, and so that will just kind of follow. Okay, the next section then deals with cardiovascular disorders, and these are going to be important for the exam. We see this tested pretty regularly, so you want to be familiar with the basic problems here that relate to the heart and the cardiovascular system, and then how we manage it, how we would assess it. It starts out by talking about the risk factors, and they're listed there, and it's good to review that. So if they have a history of MI, that certainly puts them at risk. History of hypertension, smoking history puts stress on the heart, of course, and the cardiovascular system. Increasing age will add to it. They're postmenopausal, obesity, diabetes. All of these different things can contribute to their risk, and so we can recognize that if we're reading a question and they list some of this in their history, then you would pick up on that they're at risk for coronary problems. Now, the next section deals with acute coronary syndrome. It says it's a clinical emergency, and it certainly is. So if somebody's having an acute coronary problem, that is affecting blood flow to their heart, and that's going to be a serious thing. So it says early recognition and treatment is essential, so that's true. In the field of cardiovascular medicine, we often say time is muscle. And so the more time it takes to get treatment, the more heart muscle we can lose. And so we need to move quickly as soon as we think there's a problem. It also states that early restoration of coronary blood flow is the first priority, and that's absolutely true. So when you think of someone having a coronary syndrome or a heart attack or some issue with their heart, it's getting blood flow to that heart is the most important thing. So most of our attention will be directed to that. Now, making the diagnosis, well, the history is a big clue, right? The classic, I'm having chest pain and shortness of breath. That's the big clue that everybody jumps on. And then we would assess them, of course, at the bedside. The EKG will be an important assessment. We looked at that before. We see changes in the ST segment or the inverted T wave or Q waves forming. Anything like that would tip you off right away that they're having an acute coronary problem. The serum biomarkers, we talked about that again in the patient assessment area, and those would be important to look at as well. So we'll see that as we get into this. Clinical manifestations are listed there. As we've said, the classic shortness of breath and chest pain is typically how it's all going to start out. That's what you're going to see on the exam. It talks about the 3 I's of an MI, and again, we mentioned that in another chapter, but here they are again. They're important. So the first I is myocardial ischemia. That's not getting enough blood to the heart. We call that a non-STEMI, okay, or an N-STEMI. That means there's no ST elevation yet, but it is the first stage of a heart attack, and it's important. If we go past that, we start to get injury. That's the second I, and now we have the ST segment elevation here. That's what indicates the injury, is the change in the ST segment. And then infarction is the full-blown heart attack, and that's when we're killing the heart tissue, and now we start to form those Q waves on the EKG. So this is a heart attack, and it's the leading cause of death from an acute coronary syndrome is what develops from this, and that's cardiogenic shock. So if the heart is having trouble and it can't pump blood, we know the pressures are going to fall. And if pressures fall, we stop perfusing. That's a life function. We call that shock. So it's all about that. And we saw that when we talked about hemodynamics, maintaining good pressure at all times. Now it talks in the next section about unstable angina and non-ST segment elevation myocardial infarction, or the non-STEMI or N-STEMI. Okay, and you can see that described there, the classic chest pain, shortness of breath. It's going to be the same story over and over again, but when you look at the ECG monitor, you don't see ST segment elevation. You might see ST segment depression instead of elevation. So that can be a different kind of a heart attack. The easiest way to remember this is that the ST segment is critical. If it's changing in any direction, either up or down, that's bad. So if they say ST elevation or ST depression, and it doesn't have to be very much, even one little tiny square change is significant. So anything going on with an ST segment should alert you to the fact that the patient's having a problem. Now the biomarkers we mentioned, so specifically the one I would have you highlight if you have your book is the first one there at the top, troponin. Troponin is a very specific marker for an MI, a myocardial infarction, and a high risk of death if it's rising above 0.1. Okay, remember normal should be less than 0.01. And so 0.1 is a significant increase from what is acceptable. So it looks like a small number, 0.1, but it's actually a very big number. And so you need to be on guard for that. So I would take the time to be sure you understand that and are ready to recognize it. If they give you a troponin level, anything above 0.1, that means you have a serious heart attack going on. The other indicators are listed there. You can look at them, the CK and the CKMB. But then number 4 lists the BNP. We mentioned that before. And that's not associated with an acute MI, but rather with congestive heart failure. So keep that separate. So you do want to check these markers, and they may show that the BNP is normal, but the troponin is elevated. So then you know it is an acute MI. But if it's the BNP that's elevated, then that goes along with congestive heart failure. You might recall we remember that by its 3 letters and 3 letters. So BNP, CHF, they go together. All right, and that's a good way to separate an acute MI versus congestive heart failure. Treatment and management, pretty straightforward. We said the main thing is we've got to get blood flow back to the heart. And so the expression, oh man, is a good one to remember. Oh man. If somebody's having a heart attack, you go, oh man. And that's OHMAN. O for oxygen, H for heparin, M for morphine, A for aspirin, and then N for nitroglycerin. There's your therapy. And so that make it easy to remember. So if they're having an acute MI, and you can tell by the symptoms and the history and then the elevated